All right, hello everyone. It's 10 a.m., so we will be getting started shortly. Just waiting for a few more people to um, join in. If you guys just want to take a look at this slide here, just to give a few notes of what is going to be happening today, I will go over a few housekeeping rules in a bit. We're just going to wait for a few more people to join on. Hi, everyone. So we are waiting for a few more people to come on, but we will get started as it's 10:03. So hello, everyone. Welcome. My name is Daniel Richella, and I am the Association Manager for iHEA's activities. Welcome, and thank you for registering for today's webinar, Empirical Examples of Equity Informative Economic Evaluations in LMICs. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded onto our website afterwards. Before we begin the webinar, I just want to go over a few housekeeping rules. If you experience any technical issues during the webinar, please use the chat box to put any questions, and I will do my best to help you as much as I can. Also, if you have any questions for our speakers, please write them in the box as well. And please ensure to make sure that you are speaking to everyone on the chat option and not privately to somebody. That way everyone can see the questions and we can all learn together. Everyone on the line has been muted. If you find that yourself has not been muted, please go ahead and mute yourself. It's to eliminate some of the background noise, and hopefully that way we don't have any interruptions. Again, if you have any questions during the webinar, please use the chat box and I'll be happy to help out as much as I can. And with that, I will pass it on to Naomi Gibbs, who will introduce today's speakers.
Thanks, Daniel. So I'm just going to take a couple of minutes to give a really brief introduction. So welcome to today's webinar, as Daniel said. My name is Naomi Gibbs, and I'm based at the University of Sheffield in the UK. So I am one of the conveners of the Equity Informative Economic Evaluation Special Interest Group, bit of a mouthful. I'm one of 5 conveners. The others are Dr. Andrew Mirrellman, who's based at the WHO in Geneva, Dr. Ijoma Adoka, who's based at the University of Wits in South Africa, Professor Richard Cookson at the University of York in the UK, and Assistant Professor Stefan Virgo, based at Harvard in the USA. So one of our group's key objectives is to encourage the development and synthesis of methods for using economic evaluation to address equity concerns. And to this end, we put together a couple of webinars this year. So the first one was in May, where Stefan and Richard introduced some of the principles and some of the methods of equity informative economic evaluation. And there is a link to the recording of that webinar on the iHEA website if you missed that and you'd like to catch up. So today's webinar moves us on to focus on some empirical applications of those methods with a focus on research in low and middle income countries. And we have 2 excellent speakers for today. Our first speaker will be Dr. Akshar Saxena, Assistant Professor of Economics at the Nanyang Technological University in Singapore. And he's going to be presenting research modelling the impact of a tax on sweetened beverages in the Philippines. After that, we've got Dr. Frida Ngalasoni, medical doctor and health economist, currently working with World Bank Tanzania and honorary lecturer at Muhimbili University of Health and Allied Sciences in Tanzania. And Dr. Frida will be presenting her work, which examined the equity impact of medical approaches to cardiovascular disease prevention in Tanzania. So each of our speakers has been asked to present for around 15 to 20 minutes, with some time after each presentation for questions. So as Daniel said, please do post questions in the chat box as we go along. The presenters will just ignore them until the end, and then I will choose a couple of the questions to put to the presenters. Depending on timings, we'll see how many we can get through. But any that are not addressed in this hour, we will put in the next special interest group newsletter that goes out, as the presenters have kindly agreed to provide answers for those. So I will hand over now to Dr. Akshar Saxena for our first presentation.
Thank you, Naomi. I'm trying to set up, let me see if I can just get this correct. Done. Is it working?
Yeah, I can see your slides. They're not in present mode yet.
Okay, so I'm just going to do this.
There we go, that's perfect.
So now do you see the main slides, right? Not my notes.
Just your slides now, yeah.
Okay, great, thank you. Thank you for helping. Hello, everyone. Hi, I'm Akshar. I'm a health economist at the Nanyang Technological University, and I'm based in Singapore, so it's 10:15 in the night here. And you might hear a few crickets chirping at the back because we are based in a tropical country, and we're in a tropical country, and we're kind of based in a pretty dense jungle kind of environment. So pardon me for those background noises, but welcome everyone. I'll be talking today about taxing sugar-sweetened beverages in the Philippines. So this is a research we did about a year ago. And coming from Stefan's research on excellent cost-effective analysis, we use his methodology to assess the impact of taxes on various health outcomes, financial risk protection outcomes, and the taxes. So I will guide you through the whole research, and I'll show you the results in the end and how our results differ from some of the other studies which have followed somewhat similar route, but have reached different conclusions and have had different results, particularly in reference to the equity part of it. So this research was undertaken by several people at different places in terms of geography and in places. So I was here in Singapore. Our principal collaborator was Adam, who is in Johns Hopkins right now, but he was in USA when this work was done. We had our collaborators from the Food and Nutrition Research Institute in the Philippines. They provided us with the data, they provided us with all the entire background. And Liesel was our independent consultant who worked on the healthcare financing, and Ben Johns at the USAID who helped us with the modeling. He had great inputs on the modeling. So based on that, where is Philippines located? This is the world map. Philippines is located out here in Southeast Asia. This is the ASEAN countries. I am based somewhere at the tip here. It doesn't even show up on the map. So Philippines has a population of 106 million. It's classified as LMIC with a GDP per capita of $3,000 USD. So why the sugar sweetened beverages are being taxed in the country? So obesity is a rising problem, and sugar sweetened beverages are a driver of obesity and contribute to burden of non-communicable diseases across all countries, and especially so in the LMIC. This is particularly true of the Philippines, where about 31% of the population, or about 56 or 55 million adults, are categorized as overweight. And what's more troubling is that the percentage of overweight youth has been increasing and has almost doubled in the past 10 years. So they used to be about 4.9% of the population, and that's about 20 million youth, and they have doubled to about 8.3% of the population. So that's a very scary trend, because it's the young people who are getting obese, and they are getting NCDs of diabetes and other heart conditions and stroke early on in their life. And that's increasing the burden of the healthcare costs and reducing the productive capacity of the country. Philippines is a relatively young country, so it's more troubling because of that as well. If you look at the top leading causes of mortality in the Philippines, so this is just the top 10 causes. Out of the 250,000 deaths, diabetes ranks at number 5 with about 27,000 deaths and about 6% of the overall mortality. This is comparable to other ASEAN countries, but it's slightly higher. So in other ASEAN countries, the burden due to diabetes, mellitus, or type 2 diabetes ranges between 4%, close to about 4% or 5%. In India and China, it increases further up to about 8%. So in Philippines, it's about 6%, but increasing. The more troubling trend is at the bottom, which is the disease of the vascular system, about 68,000 deaths, or about 15%. And lastly, the disease of the heart, they are the top most condition, contributing to about 27% of the deaths. So based on this troubling trend, Philippines has been working on several pieces of legislation. So sugar tax was one of those first ones. Smoking legislation is on the cards, it's been implemented. Alcohol is being taxed as well. So Philippines has been taking an approach on addressing the risk factors for these NCDs. So today we just focus on the sugar sweetened beverages because of that tax came in the earliest. So the natural question to ask is how much sugar sweetened beverage is being consumed in the country? This chart shows on a per capita daily basis. On the y-axis, it's the per capita sugar sweetened beverages consumed per day in liters. So we use the metric system here. So conversion to US would be different. And on the y-axis, on the x-axis, I show the quintiles. So one is quintile 1, and quintile 5, the richest quintile, the wealthiest quintile is labeled as 5. So if you see the distribution of SSV consumption, it kind of reflects the income levels. It's the lowest and the lowest socioeconomic status, and it increases as we reach the higher socioeconomic status. So that trend applies. Although this trend is quite different in countries like India and China, where the sugar sweetened beverages consumption in the lowest income quintile and the second income quintile is pretty high and actually exceeds the middle income quintile. So Philippines has an increasing trend, a pretty unilateral increasing trend. Now the troubling parts are if we segment the distribution by age groups. So at the bottommost, let's start with the age 0 to 5. The pink line shows the age 0 to 5. So they start at about 0.1 liter or about 100 ml of sugar sweetened beverages per day. And it increases all the way up here to more than 0.2 or 200 ml of sugar sweetened beverages per day. Now this, mind you, this is the age group of 0 to 5. The daily recommended value for this age group for sugar consumption is about 25 grams of sugar. If they are consuming about 100 ml of sugar, 100 ml of sugar sweetened beverages per day, they are already consuming quite a lot of sugar that is needed for them for the day. And this does not account for chocolate milk that they consume on top of the sugar sweetened beverages. This does not account for the desserts that go as part of their regular meals. So this is just pure sugar sweetened beverages, and it's very alarming. Naturally, the next biggest consumers are ages 15 to 19, the teenagers, who are the second highest consumers here. And in the ages of 20 to 24, when students are in university and beginning their first jobs, they are the highest consumers of sugar sweetened beverages. And this is the alarming segment of the population, the 15 to 19-year-olds to 24-year-olds, because this is when they start becoming obese. This is the age group where the obesity prevalence has doubled. As they grow older, the consumption of SSBs reduces. So in the age groups of 70 to 74, or in the age groups of 80, the sugar sweetened beverages consumption is actually the lowest out here. So this chart is important both for understanding the consumption by different income quintiles and by different age groups, because the disease incidence affects both the different age groups and different income quintiles. Why is it still important in the Philippines? Because the sugar sweetened beverages is still a growth industry. There have been very limited checks on them, very little regulation, all sorts of, all varieties of SSBs are still entering the market. There had been other forms of industry regulation, for example, regulation on the ban of advertising, similar to the smoking advertising bans. Advertisements like these have been banned. Small shops are difficult to ban, so the regulation is on the industry side, but these small shops where these sugar sweetened beverages get sold are harder to control. So government has been thinking of different ways of looking at controlling the sale of sugar sweetened beverages. One of the forms is to reduce the consumption of SSBs in school canteens. That's an active legislation that's been put in place, that schools cannot sell sugar sweetened beverages. There cannot be any advertising in the nearby areas, so on and so forth. And there could be product labels that come and say that adding sugar leads to obesity and tooth decay. So there have been different forms of regulation for sugar sweetened beverages. What WHO says is that increasing tax is one of the most cost-effective policy solutions for taxing it, for curbing the increase in SSB consumption. And WHO kind of gives a range of about 10 to 20% tax, or the increase in price to be about 10 to 20% of the retail price to be, for the tax to be effective. And Philippines is one of the 27 countries, I think at my last count it was about 27, or it has increased to 32 countries now, which have introduced taxes on the sugar sweetened beverages. There are other countries like Chile, France, Mexico, several states in the US or municipalities in the US that are implementing taxes on the sugar sweetened beverages. Even in the Middle East now, there is Saudi Arabia's coming up with a tax policy with a very high tax of almost 50%. So different countries are experimenting with different levels of taxes. So what did Philippines do? On the 19th of December in 2017, President Duterte signed the budget law, and the tax was supposed to come in on 1st of January 2018. So this is him signing the tax law. And what did the tax actually provide? The tax was on sweetened beverages. It was a PHP or Philippine peso of 6 pesos per liter for beverages, which had a caloric and non-caloric sweeteners, and a higher tax, or double the tax, of 12 pesos for beverages that had high fructose corn syrup. Now, for industry professionals, it was easy to distinguish which one is caloric and non-caloric sweeteners and which have high fructose corn syrup, but for the consumer, it was very difficult to identify. Even as researchers, when we tried to look at which products would be taxed and not taxed, it was very difficult for us to tease out which is getting taxed, how much is it getting taxed, and what was the previous consumption. So it was quite difficult in implementation. What was excluded from the tax was all sorts of milk. So even if chocolate milk like Milo, if it was sugar, if there was added sugar, that was excluded. Coffees were excluded. Fruits and vegetable juices were all excluded. So basically all the substitutes for sugar sweetened beverages were excluded. Interestingly, so the point interesting in Philippines was that milk for children was excluded and beer for the adults was excluded from this tax. Now let's come to the methodology for how did we assess the cost effectiveness of this proposed tax. So we did a modeling when the tax was being implemented, and now we are going in to do the actual, we have a study coming up which will be looking at the tax's actual impact. So this is a pre-implementation study. So based on Stefan Werge's cost-effective analysis model, we have a policy instrument like an excise tax and SSBs that is expected to reduce the consumption SSBs. It has two effects. First is the generation of tax revenue because people are still consuming SSB, so it gives tax and it provides a bit of fiscal space for the government. And it also has health gains whereby there's a lower incidence of diseases, there's reduction in premature deaths. That health gains get translated into lower out-of-pocket costs. The OOP is the out-of-pocket cost for sugar-sweetened beverages related diseases. It also leads to changes in sugar-sweetened beverage related household expenditure. And it has a financial risk protection because people are not spending money on their diseases. They do not fall into poverty. And so this is the basic analysis for the cost-effective analysis. What we do with the extended analysis is we segment this entire analysis by income quintiles to show how the tax is impacting both the disease incidence and the financial parameters for each of the different quintiles. So with this, let's dive into the methodology. Now this next slide is much more detailed. Let me walk through it. So we did three parts to the analysis. In the first part up here, there was a price change due to the tax. Sorry, I'm not sure what's happening. There was a price change, and then we used the price elasticity and the price pass-through to estimate the change in sugar-sweetened beverage consumption. The change in sugar-sweetened beverage consumption was translated into energy intake, and that energy intake led to a change in the body weight. Assuming the height of the adult stays constant, we could estimate the change in BMI. So that's the first part of it. Once we had the change in BMI, we converted that change in BMI to different risks. So we had risk of type 2 diabetes, we had risk of IHT and stroke. We used live tables to convert them into gains, to health gains in terms of lower incidence of the disease and in terms of reduction in premature deaths. Once we had these health gains, we converted them into financial risk parameters. We used the insurance market to estimate how much subsidies the government is going to give out and how much is the copay from the insurance side to lead to the out-of-pocket expenditures. And we did by the income distribution to see how much was the financial risk protection. So very quickly, we used the baseline price, the baseline consumption multiplied by the pass-through, multiplied by the change, by the elasticity to get the new consumption. This is how we estimated the change in consumption. Next, we used the change in consumption multiplied by the change, the energy density of our sugar-sweetened beverages to estimate the change in energy intake. That change in energy intake is assumed to change the body weight. So we had a 94 kilojoules per day leads to 1 kilogram of body weight change. Assuming average height, that leads to change in BMI for different households. And we did it by different age groups and different quintiles. Then we took the current population. We used the current T2DM, IHT, and stroke incidence. We had an intervention population where because of change in BMI, we had change in the incidence for all the three conditions, and the health gains was just the difference between the two. Lastly, we took the reduction in incidence multiplied by the annual healthcare costs. So we took the annual healthcare costs in hospitals for type 2 diabetes. It's about $256 to get your diabetes treated. For IHT, it's about $216 USD, and for stroke, it's about $600 USD. These are annual healthcare costs in the hospitals. We multiply by the out-of-pocket payment proportion that the individuals are supposed to pay. So in Philippines, quintile 1 pays about 20% of their healthcare costs as out-of-pocket costs, whereas quintile 5 pays about 83% to estimate the out-of-pocket savings. And lastly, for estimating the financial risk protection, we simulated a population with the income distribution that's currently prevalent in the Philippines. And we selected the sample which had the disease incidence avoided. So we applied the incidence avoided to the sample that we simulated. We applied the out-of-pocket cost distribution, and we estimated how many people will avoid the catastrophic health expenditure. And we summed up the total number of people. And lastly, we calculate the tax revenue, which is just the SSB consumption, the new SSB consumption multiplied by the tax that they're collecting, gives us the total tax. Now let's look at the results. So we estimated there will be a total reduction of 5,913 deaths over 20 years. So this is about 300 deaths per year. In terms of percentage reduction, it's about 1% deaths, 1% reduction in annual deaths due to type 2 diabetes. For IHD, we had about 10,000 deaths reduction. It's about 0.5%. And for stroke-related deaths, we had a reduction of about 400 deaths per year, or a total of 8,000 deaths. And this also is about 0.6% of the total reduction in deaths. Now let's look at by the different quintiles. Now this is where the picture becomes more interesting. So the number of deaths averted in the quintile 1 was the lowest, whereas the number of deaths averted in the quintile 5 was the highest. This primarily comes because the SSB consumption in quintile 1 was the lowest. So this kind of follows the same trend of SSB consumption. Now imagine if it's a different country with a different SSB consumption profile, we could have a different profile for number of deaths averted. In terms of healthcare savings, we see a different profile emerging. So for quintile 1, we estimated that there was a larger decrease in healthcare costs as compared to the quintile 5s. This is because of the way the healthcare system is set up. In terms of financial risk protection, this is the reduction in out-of-pocket payments. So remember in the quintile 1, they were only paying 20% of their costs as out-of-pocket payments, whereas in the quintile 5, they were paying about 83%. So similarly, the reduction in out-of-pocket payments per quintile was highest for quintile 5 and the lowest for quintile 1. We had a total of 13,000 or about 14,000 catastrophic health expenditures averted, and as expected, the most of them were from, almost about 8,000 of them were from the quintile 1 and only about 1,400 from quintile 4, with none in quintile 5. And lastly, we estimated that the government is going to get about 813 million USD in per annum tax revenue. So this forms about 0.26% of their nominal GDP. So it's significant in some way. The tax revenue was distributed across income quintiles, with the least tax coming from the quintile 1 and the highest tax coming from the highest income quintile. So about 14% of the tax came from quintile 1 and about 26% comes from the quintile 5. So this is where you see the equity part coming in as well. The tax burden is the lowest for the lowest quintile and the highest for the highest quintile. Our research had several issues. Our model was very conservative. We did not distinguish between which were the 6 pesos and the 12 peso items. We did not have price elasticity for Philippines. We had to use estimates from other countries, and we did not model people switching from sugar sweetened beverages to chocolate milk for children and switching from SSBs to beer for the adults, so that we could not do. And we could only look for the 3 major health outcomes. There are other health outcomes that are affected by obesity, and we could not look into those. We also assumed that the risk was the same across quintiles, and we did not have any estimates for the outpatient costs. So if you're looking for type 2 diabetes, primary healthcare plays an important part, and outpatient costs form a big part of the care, and we did not have any such things. And we didn't estimate anything for the productivity losses, which could be very significant for quintile 1, or the transport issues, caregiver issues, which are very much prevalent in quintile 1s and less so in quintile 5. Lastly, we assumed that we concluded that our tax was roughly fair because the tax savings were lowest, the tax incidence was the lowest and the lowest in quintile, whereas the disease burden kind of reflected the SSB consumption. So wealthiest quintiles were the most affected by the tax. And this is kind of different from the study that was done in Mexico that showed the reductions in consumption were the highest amongst the lower SES than the higher SES because of the way the elasticities were. And even the maximum reduction was in the lowest socioeconomic status. Even Australian study had a different results than us. And we also showed the role of state in financial protection, because in the Philippines, the way the insurance was set up is that they provided the most amount of care for the lowest income quintile. That's where we saw there was a higher financial risk protection for the lowest income quintile, even with the same disease incidence. There was quite significant revenue that was being generated. but we do need to measure the cost effectiveness, the overall current cost effectiveness once the plan has been implemented. We do not know how the industry is going to respond to this. Their work talks about retrenchments, there were talks about other things, but it's still a matter to be studied. And implementation is definitely a major issue because it's a low and LMIC. How do we implement the excise tax? How is it collected? How well is it enforced? Matters. So that remains to be seen, and that's where we are going to go into another study. Thank you everyone for listening to me. I look forward to your questions.
Thank you, Akshar. That was really interesting. We've already got a couple of questions in the chat, so I'll just go straight into those if that's okay.
Sure.
So the first one that came in was when you were looking through your methods. So they asked for step 1 about whether you consider price elasticity of demand changes by income decile. I know you mentioned later on that you had to borrow them from other countries, but I wonder if there's any more detail you can give on that.
Sure. So when we estimated the change in consumption, we did estimate the change in consumption by different income quintiles. So here I give you an example. So we had the sugar, sweetened beverage consumption by different income quintiles, and we multiplied them by elasticity for different income quintiles. And these quintiles, we used the elasticity estimates from Mexico.
Brilliant, thank you. And then another question from Anton, a couple of questions. What perspective was this analysis done in? Did you include the costs associated with a new tax or tax collection? And he's also asked, should we include consumer surplus or the loss thereof?
Thank you. That's a very good question. So no, we did not. I think that's the caveat that we put in. We did not consider the implementation costs. That's one of the major issues. And we are going back into Philippines now, collaborating with FNI again to look into the issues of tax collection. We only concentrated on the healthcare costs that were coming out of hospitals, not even the primary healthcare. Is that okay?
Yeah.
Yeah. Okay.
Okay, so I'll just ask one more.
Sure.
One person's just wanting to check about the mechanisms between higher tax revenues despite lower consumption.
Mm-hmm. Sorry, so what is the question?
How does the government realise the higher tax revenues despite a lower consumption of sugar sweetened beverage?
So the tax revenue is coming from multiplying so this tax is the post-tax consumption. So after multiplying from the elasticity of different income quintiles, what is the new consumption? And then we take the tax collected for that amount of liters. So for example, a person was consuming 1 liter of SSPs before, and now because of change in tax, he consumes 0.6 liters. So what is the tax for that 0.6 liters of consumption? And we multiplied by just the unit tax by the total amount of consumption for each of the quintiles. Now, of course, there will be several. So this is just a pure estimation. There will be leakages along the way. So this is just pure on that.
Excellent, thanks, Akshar. There's a couple of other questions, but I'll put them to you after and we'll circulate them. So I want to make sure we've also got enough time for Frida. So thank you very much, Akshar.
Thank you, everyone.
If we can now, if you stop sharing your screen and if Frida is happy to share.
Okay.
Naomi will confirm when you see my screen, please.
Yeah, I can see your screen.
Thank you. And as Naomi introduced me, I'm Frida Ngalesoni and I'm based in Tanzania. I'm a medical doctor and health economics, currently working with the World Bank Group and lecturer at Muhimbili University. So this evening I'll be talking to you or presenting a work we did on equity informative economic evaluation when we're looking at the medical interventions for primary prevention of cardiovascular diseases. This was done way back in 2016, but I believe it's still valid to date. So background, Tanzania, like many other low-income countries, is facing a double burden of disease where NCDs are, and especially cardiovascular diseases are on the rise. As you can see from the data we the current data from Global Burden of Disease, cardiovascular diseases is actually occupying the first, it's ranking first in terms of deaths caused by cardiovascular diseases. And different from high-income countries, victims in low-income countries like Tanzania are usually young adults, they're poor, and it affects both males and females. But currently, the CVD efforts are upcoming in the country. There are several policy documents and guidelines coming up on NCD and CVD in particular, but they're usually inconcrete and imprecise. And as expected, data is severely scarce to inform preventive measures. So what we did in this work, it's actually a series of work we did on primary prevention of cardiovascular diseases in Tanzania, where we started with looking at the costs of primary prevention. And our conclusion was that this cost is it's really costly to have primary prevention at the individual level. Because we looked at this at the societal perspective, and most of these costs actually borne by the patients. And then secondly, we went further to look at the medical interventions, the cost effectiveness of the medical interventions for primary prevention. And we concluded that these medical interventions are actually very cost effective in some of the CVD risk factors, and especially the low and the moderate and the high. A bit not that cost effective, not very cost effective for the very high CVD risk. So what's the rationale for this piece of work? We know that individual-based preventive measures sometimes do increase inequalities, and we were to look at the different approaches in the provision of medical interventions to see which one of these different approaches would be more favorable in terms of efficiency, inequality, and the combination of both efficiency and inequality. So how did we do this? We used a model which we did a Markov modeling and analyzed closed Tanzanian cohorts. And this is a model which was used on the previous work, where we looked at the cost effectiveness of the different medical interventions. And here we separated or categorized the cohort into three different risks: low risk, moderate risk, and high risk. And these cohorts transited in the different health states from no cardiovascular diseases, and we made sure that these are cohorts which doesn't have any cardiovascular disease, because we're talking about primary prevention. And these transited from no cardiovascular diseases to having moderate, mild, moderate, and severe stroke, and also myocardial infarction, and also a death state. The starting age was 40 years, and they did transit according to the age-specific risk of myocardial infarction and stroke, depending on the risk reduction of the medical interventions. And you'll remember that the medical interventions we used were those ones which were cost-effective from our previous work. So we analyzed 4 preventive scenarios, which I'll explain a little bit in the next slide. And the resource inputs and the medical interventions and other model inputs are from the 2 previous papers, which looked at the cost and the cost effectiveness. So these are the absolute risk approaches which we analyzed. The first one was the baseline approach, where we assumed that nobody was given, the cohort of Tanzanians of low, moderate, and high risk were not given any primary prevention interventions for prevention of cardiovascular diseases, the medical interventions. So this was our baseline approach. And then we had a very ideal or best scenario approach, where we looked at the European Society of Cardiology approach, which actually advises that anybody who's above 5 to 10 should be given medical interventions for primary prevention of cardiovascular diseases. However, for resource constrained countries like Tanzania, a threshold is usually a bit higher, whereby when a person is at a risk threshold of between 10 and 20, that's where you can start the medical interventions for primary prevention. But then the Scandinavian countries have actually gone further and devised differentiated risk threshold by age, whereby younger ages are given a lower risk of starting the medication, while the older are given higher risk. And these are for obvious reasons, which are the caveats or the side effects of the limitations, if I rather call that, of the absolute risk is usually it prioritizes the elderly over the young, and it also does not consider expected benefits from treatment. It ignores the relative importance of loss of life at different ages. So in other terms, it discriminates the young into getting this. And there are some studies which has proved that the expected benefits from treating the young are actually higher than treating the elderly. And therefore, we wanted to see which one of these different approaches, and especially comparing the guideline, the WHO guideline versus the differentiated risk threshold by age. See which one is more efficient, which one will reduce inequality, and then we look at the trade-offs between the two by considering the achievement index. So our equity analysis, we used life expectancy at the age of 40 as a proxy of efficiency, and then we used Gini coefficient to look at the inequality in the age of in the life expectancy at 40 as well, and then compared the trade-offs between efficiency and inequality analysis. So our results are as follows. We showed that the WHO approach, whereby it's a single risk for all ages, was less efficient in terms of life expectancy at the age of 40, whereby you can see that with the WHO risk, you only gain 26.6 years, while with the differentiated risk, you will gain about 2 years more than the WHO approach. And when you look at the Gini coefficient, the Gini coefficient was lower with the differentiated risk, meaning that it was more, less inequitable to the Tanzanian cohort when you do the differentiated risk by age compared to the WHO approach of a single risk. We also showed that these approaches did not have any distributional conflicts in terms of the approach which reduced the inequality was also the approach which was more efficient in terms of increasing the number, increasing the age, the life expectancy at the age of 40. But one thing that we did is that we had to make sure that these two approaches had the same total cost, so that we can compare these approaches regardless of the costs. But then when you look at the European Society of Cardiology approach, was the best in terms of life expectancy at the age of 40. It had the lowest Gini index and also the highest achievement index. However, you might notice that the total cost of this approach is really high. So something that a low income country or resource constrained country like Tanzania may not be able to afford. So what are the limitations of our work? As you can notice that we just looked at the overall inequality without disentangling which was the fair versus unfair, or looking at inequity, if we might call it like that. We also only looked at, because of data constraints, we looked at life expectancy and not the health-related quality of life, changes in the health-related quality of life. And our baseline scenario, where we assumed that a Tanzanian cohort might not receive any primary prevention for cardiovascular diseases, may not be realistic, even though it might kind of picture that situation where the country now still is on the use of individual risks, like only looking at single individual risk like hypertension and cholesterol, and not the absolute risk. So even though not that realistic, but it pictures some of the reality in the ground. So what is our conclusion? this work does not, it doesn't equate to the distributional cost effectiveness analysis or the extended cost effectiveness analysis in terms of methodological, but it just illustrates the evidence on cost and outcomes within a disease area. For instance, here in cardiovascular diseases, in our
Oh, Frida appears to have frozen. I don't know if it's me or just her. Daniel, are you still there?
Yeah, I don't believe it's, if she's frozen, I think it's for everybody.
Oh dear. Okay, that's a shame. She was just on her concluding remarks.
Yeah,
but
she stopped sharing the screen, which means she's, I don't think, longer with us.
Been cut off. Yeah. Oh, that's such a shame. But that is the nature of doing online events, I suppose. So she was just on her concluding slide. I guess it might be difficult for her to log back on, so I'll probably just wrap things up now. But I would like to say, if you were going to ask a question of Frida, I know I had a couple in mind, do put them in the chat box now, and I will put them to her, and she can, I'm sure she said she was happy to answer them after the event, and then I can send them round. A really interesting approach, I thought, using a Gini index for life expectancy, and not one I had seen before, so I was quite interested in that method. So I just wanted to say then, thank you very much to our two speakers who've very generously shared their expertise and their time today. I know it's not an easy matching up time zones either, so thank you very, very much. And if anybody wants to sign up to the special interest group and doesn't get the newsletters, do email me. It's n.gibbs@sheffield.ac.uk, or you can just go on the iHEA website and sign up to the special interest group if you're a member of iHEA. So I will finish it there, I think. Thank you very much, Daniel, for supporting it as well.
Thank you.
Goodbye, everybody.
Perfect. Thank you, everyone.
Thank you. Bye.